Hello, dear friends and colleagues. Today we are at 4D 3.0 session where we have detailed discussion and dialogues, in particular in relation with Indian diabetics. And for this discussion, today we have three eminent speakers with us. First, I would like to invite Dr. Purneshwar Pandey. So he is a cardiologist at Fortis Rajan Dal Hospital, Vasant Kunj, New Delhi. Hello, Dr. Purneshwar.
Hello, sir. Thank you. Thank you for your kind introduction. And today we'll be discussing. Yeah.
Yes, I hope Delhi is okay with the pollution index that we are hearing about.
I think it is much worse outside, and it's really difficult to go outside in this polluted environment. But we are still coping it up.
Okay, so I think it's what we are learning from the news is probably true. So I think
it's exactly true.
Absolutely, best wishes to you. So next we have Dr. Bhanu Mishra. So he is a nephrologist.
Office. So
okay,
it's much better.
Yeah, same here.
So great. And for the third eminent speaker, we have Dr. Pawan Goel, who is from Lucknow. He's an assistant professor at Sanjay Gandhi Postgraduate Institute of Medical Sciences. He's an endocrinologist. So hello, Dr. Pawan.
Good evening, sir.
Yeah. So how's the weather in Lucknow?
Sir, I would like to correct that I was an assistant professor in SGPGI 1.5 years back. Currently, I am in LLRM Meerut. So it's the same here.
Same, true. Yeah. So I think probably slightly better than Delhi or worse than Delhi.
Almost same, sir. There's no difference, I would say.
So I think today we are going to talk about something different, where we are going to talk about heart failure, CKD, and diabetes, where two guidelines converge. So I think as intellectuals, I think our main job is to always diverge, but this time we are going to search our convergence points in perspective of various parameters in relation to heart failure. So my first question would be to Dr. Pawan. So what is your perspective about diabetes and why it is important that an endocrinologist role is important when it comes to talking about heart failure, in particular with relation to diabetes?
So it has been proven time and on that the glycemic control is a very important determinant in both micro and now also the macrovascular complications. And the CV events and the atherosclerotic events are the most common cause of mortality in diabetic patients. So good glycemic control and good endocrine management helps us avoid the cardiovascular events and heart failure developing in diabetic patients. The AD also recommends that we should consider screening with anti-proBNP in patients with diabetic for heart failure. So the importance is becoming more and more prominent these days.
Okay. And a question to Dr. Purneshwar. So I think a same question that I would like to repeat to you. Cardiologist's role is important, but why do you think we are talking more about heart failure in diabetics than what we were talking earlier? Do you think it is just that DAPA study was published, or is there something more that probably we now know better?
No, so basically heart failure is much more prevalent in diabetic population as compared to the normal population, both because diabetic population have a cardiomyopathy that probably we term as diabetic cardiomyopathy without any cardiovascular disease. There are many, even the cardiovascular disease or the coronary artery disease is pretty much more prevalent in diabetic patients as compared to non-diabetic. So I think that when we are encountering the heart failure patients, almost 60 to 70% of them are turning out to be diabetic. And it is very important to understand the management of diabetes as well as hypertension in that heart failure in that perspective.
Okay. So coming to Dr. Bhanu, so first of all, I think we need to recognize that in the CKM syndrome, I think nephrologists are always given a step daughter or step son treatment because they are not talked about all. So what you would like to say about as a role of nephrologist in heart failure? So something new or is it not important? What you would like to say on that?
See, the nephrology role actually plays an important part. We as doctors and fraternities have tried to divide into endocrine, cardio, and nephro, but the body does not behave in that manner, and everything becomes interlinked. In CKD patients, there are challenges to control diabetes. In CKD patients, there is a big challenge to control the cardiac issue as well. Their chances of getting a cardiac issue is far more than a normal diabetic. So, a diabetic with kidney disease patient gets more cardio issues. Sugar control becomes very erratic the moment kidney kicks in.
Right.
So the role of a nephrologist definitely, I believe, is prominent in when we talk about this metabolic disorder. There are a few points that we need to understand that from the nephrology perspective, the moment diabetic hits in, especially with proteinuria, the loss of GFR that we see is tremendous. It is the only thing that beats diabetes kidney injury is probably an RPGN, which is like the heart attack for kidney. It's like rapidly progressive glomerulonephritis. Is something which kills the kidney fast. Otherwise, there's nothing that beats diabetes. It takes almost 12 ml of GFR every year. So the moment you get proteinuria and let's say you're at a level of 60 GFR, you'll be stage 5 in very soon. On top of that, proteinuric diseases gives you a lot of comorbidities of edema, blood pressure not getting controlled, and BP doesn't get controlled. You get fluid overload. The GFR even kicks up, goes away faster, and you are prone for infections because of the fluid overload state. So that also has to be kept in mind. So a role of nephrologist is to guide about salt and water, is to guide about good hemoglobin levels because kidney also plays a role there. So I believe we have a center stage.
So I think it's just probably like a trinity that is in work. So it is so that just we have the Brahma, Vishnu, and Mahesh trinity going on in our Hindu culture system. Similarly, I think it's the CKM, so the cardiac, kidney, as well as the metabolic part, which can be dealt by metabolic physicians or endocrinologists. I think all working in tandem towards achieving this common goal of treating heart failure. So again, coming to Dr. Pawan, so what are the common lenses that you look through it? So what are the common points, especially where we see a overlap between heart failure and glycemic control? So are there particular pathways that you would like to describe, or are there some common points that we can share? And then I think each of us talk about the pharmacological drug aspects in relation to our system, and then I think we can club it together. So coming to the glycemic control, so which are the 3 drugs that I think would be your prominent points that you would like to keep whenever you are targeting a good glycemic control in a patient with heart failure with diabetes?
So the first and foremost would be, sir, SGLT2 inhibitors. They are both disease modifying in the heart failure patients and also in the patients with nephropathy. They help in stopping the progression in both the disease, and also helps in optimize the glycemic control. Second would be the GLP-1 receptor agonist for patients with the atherosclerotic cardiovascular heart affliction. They would help in preventing further attacks and also lowers the insulin need and other use of other OHs. And third, I would think that I would prefer insulin in such patients and avoiding sulfonylureas and other OHs which can predispose to hypoglycemia. These would be my 3 lines of management.
So I think glycemic control, when we talk about glycemic control, I think we have to talk about that. First is achieving a good glycemic control. Second would be achieving a good weight loss. And nowadays that can be done with GLP-1 analogs, giving a good glycemic or metabolic profile that can be achieved by SGLT2 inhibitors. And I think prevention of hypoglycemia, which is often missed about and not talked about, is an equally important part by avoiding probably a little lower dosages of sulfonylureas and wherever necessary, using the right amount of insulin dosage that I think can take care in a better way. I would like to go over to Dr. Purneshwar, where I would like to talk to you about what do you think about the RAS blockade that is there in the cardiac system, and especially about ARNI is something where I would like you to elaborate, because lots of physicians still don't have too much background or knowledge about what ARNI entails and what is it function, especially in relation to heart failure.
Right. So I think that it is one of the major drugs nowadays where we are treating majority of the patients with heart failure with reduced ejection fraction with ARNI, and rather replacing ACE inhibitors or ARBs in majority of such patients. And we are also seeing a dramatic improvement in the functional class in such patients. I think that ARNI, after the majority of the trials which have shown benefit like Paradigm HF and the Paramount, they have shown that ARNI, because of a excess, so it is basically sacubitril as well as valsartan. So we know that sacubitril is basically a neprilysin inhibitor. So earlier also these drugs have been tried in various permutation combination, but not to that effect. But I think that, see, ACE inhibitors or ARBs we have been using since time. So
Right.
when we talk about the ACE inhibitors like enalapril, perindopril, and ramipral, we have been using it since times, and ARBs have definitely helped us, but they did not have a major advantage over ACE inhibitors when we talk. Only in certain situations where ACE were not tolerated, then we were using ARBs. But nowadays, what we are seeing that even the patients who are well tolerated on ACE or ARBs, they are actually replacing them with ARNIs, especially in patients with heart failure with reduced ejection fraction. And we are seeing that the functional class, the patient's salt and water, or you can understand the fluid balance, as well as the other things are improving dramatically. So when we talk about the four pillars of the heart failure, that is beta blocker, MRAs, SGLT2 inhibitor, and the ARNI, I think the most important two are actually the SGLT2 and the ARNI. And
Okay.
in terms of ARNI, I can say that only and only problem in majority of such patients where we are treating reduced ejection fraction is the blood pressure. So
Okay.
when we are treating not exactly in the, you can say, CKD population where the blood pressure is slightly on the higher side, but
Right.
patients who have stage 3 nephropathy or diabetic nephropathy, where the creatinine is somewhere around 1.2 to 1.5 with mild microalbuminuria. In such patients, the patients with reduced ejection fraction have a blood pressure of around 100 to 110 systolic in
Right.
majority of. And there, what we encounter is that initiating ARNI, especially in Indian patients, is
Okay.
slightly difficult because majority have a fall in the blood pressure. So
Okay.
it is not like that what the US or the Western counterparts are saying that the dose of 200 will be twice a day is the dose where we can achieve the best outcomes. But in India, we are not able to reach to that doses. But
Okay.
I think that whenever we are encountering a patient of heart failure with reduced ejection fraction who are even well tolerated on ACE inhibitors or ARBs, we should try to switch it to ARNI at some
Okay.
point of time.
I think, Dr. Purneswar, that's an important point. Now, I'm not trying to be a news anchor here and start a debate between a nephrologist and cardiologist. But Dr. Bhanu, I would like to ask that Dr. Purneshwar spoke eloquently about ARNI. So, do you think that ACE inhibitors and ARBs have no role at all, or you still think that there seems to be an important role where it should be given a fair trial? And which are the particular indications where you would like to use ACE inhibitors and ARBs. So, what's your opinion on that?
ARNI is a great class of drugs, and we also personally use them with our cardiology colleagues, no matter how much we fight over rise of creatinine and potassium.
True.
But we have to understand in the context of the Indian economics,
Right.
where a simple ACE inhibitor or an ARB would be pennies, and giving them ARNI would be difficult. On top of that, in the moment patient becomes CKD, there will be always an add-on of a few drugs that we have to give from nephrology perspective. The
Right.
amount of the number of drugs, the polypharmacy that they get, and the zeros that get added on to their bills becomes
Right.
too much.
Right.
So in that context, I would suggest if you see, you have to customize it to your patient's
Right.
pockets as well. Where
Right.
if you can give them, instead of giving zero or nil, ARNI or nothing, is it
Right.
better to give them some other ACE-ARB which can be easily available to them, and
Right.
they can afford it. That's one aspect of it.
Right.
Apart from that, ARNI does a great job. Plus, you have to see. I think the trials are coming in. Dr. Pandey can give us a head view. Even in preserved ejection fraction, I think ARNI trials are going on, and still they are saying it's good in that. In most of our patients, you can continue ARB in both HFpEF and HFpEF patients, and no need to change the drug as such.
Right. So I think that's an important perspective that you told, that still ARNI is a good drug to be treated in heart failure, but physicians shouldn't get upset if their patients cannot afford ARNI, because an equivalent benefit is still provided by ACE inhibitors and ARBs, and they still remain a good choice of drugs if at all ARNI is not affordable to these patients, is what I would like to have a key message over here. And Dr. Bhanu, I would like you to also elaborate a little bit about Finrenone, because there is still little knowledge about, not much in the physician community, about what exactly entails with Finrenone and its role in relation to heart failure.
Yes. So diabetes has multivariate, factorial ways of damaging kidneys and other systems as well. One of the ways is, inflammation and fibrosis. So if you talk about MRAs, right from the spironolactone times to the eplerenone time to now the Finrenone time. The Finrenone is taking a lead over. The side effects are way less. Hyperkalemia to some extent is quite less with it, and it affects that pathway where it prevents progression to fibrosis. So that is one totally different mechanism for how ACE-ARBs and SGLT2 are working. So it is a drug which helps you tackle a different mechanism, which is extremely good and should be encouraged. Then the other issue with it is initially all the trials were done only on ACE-ARB patients who are taking already on an ACE-ARB.
Right.
So in Indian context, where we see if your patient comes to you with a good GFR, who is already on an ACE-ARB, you add on a SGLT2, and if it's proteinuric, you're adding a non-steroidal MRA like Finrenone, where it would give us good benefits. It reduces proteinuria, and studies have shown beyond doubt that it is helpful in reducing the progression towards end-stage renal disease. The only pointers that are add-on we have to understand, one is the cost effect still is way too high with this drug, and the other aspect of it is the hyperkalemia.
Okay.
Again, because ACRB itself, people are unable to tolerate because of hyperkalemia. You add on this drug and potassium becomes a big problem. But I believe we are very shortly the drug is going to get launched for potassium. I'm sure those must be giving you hard times in your OPD, introducing you to a great drug called Lokelma. It's in the pipeline, and it is called as a therapeutic enabler. And I would be happy, but if cost is kept aside, I think that will be a great add-on to our armamentarium, where you can still continue ACRBs and non-steroidal MRAs along with this drug, and it will be very helpful.
So I think that's an important message. So first of all, I think glycemic control is an important. It's absolutely of importance, especially when controlling heart failure and diabetes. Using SGLT2 inhibitors and GLP-1 analog forms the keystone. Prevention of hypoglycemia forms an equally important. As told by Dr. Purneshwar, I think ARNI is an important part, and with that, beta blockade is equally important. And as highlighted by Dr. Bhanu, we have Finrenone, which is an important molecule, which is an add-on. And ACE inhibitor and ARBs are a good choice of drugs, especially in those in non-affordable settings, and even in right set of patients when used wisely and used properly. So a last question that I would like to ask about this common goals. Yeah, Dr. Bhanu, yes, you can definitely.
There was one point I would like to ask Dr. Purneshwar.
Yes.
We have heard in a few cross-talks between cardiology and nephrology is the role of vericiguat, especially in the type of patient you described at the BPs of 100, 110, where you are unable to introduce ACRBs, and sometimes SGLT2 inhibitors also sometimes cause a little bit of hypertension. Where do you see the role? They are describing it as a fifth pillar.
Yeah. So I think you must have heard about the new trial which Victoria, this vericiguat has come out with, where actually initially it was used as a drug, where it was used for worsening heart failure. So despite the 4 pillars, using those 4 pillars, if the patient is having a worsening heart failure, then vericiguat was an add-on. And in
Absolutely.
that trial, that was a Victoria trial, we found that somewhere hypotension, slight hypotension, and some episodes of loss of consciousness or syncope was there. But now, what the latest trial is showing is that even the patients who have a stabilized heart failure, or you can say the patients in NYHA class 2 and class 1, those who does not have too much of symptoms, adding of vericiguat is adding to not because this trial is actually negative. The trial is called Victor trial, so it is actually negative in terms of heart failure hospitalization, but it is positive in terms of all cause mortality and preventing sudden cardiac death. So if you read the trial very closely, definitely it is a add-on drug because first it is a soluble guanylyl cyclase activator. So this mechanism we have been studying a lot, right? Even in pulmonary hypertension, we have a drug called riociguat, which we are using, right? So this is a added mechanism. Like you said that in Finrinone, we are trying to actually attack a separate pathway, which is leading to inflammation and fibrosis. In the similar way, this is also one of the pathways which is responsible for exacerbation of the heart failure symptoms. So I think that Vericiguat. So personally, Vericiguat again the same thing that the cost is important, right? Similar to Finrinone and the other drugs, the cost is a prohibitive factor right now in Vericiguat. But I use it in two special settings, right? First
Okay.
is where the patient is not able to tolerate ARNI, especially
Right.
because of BP. Now, what see, we are using ARNI in literally many patients. Now it is actually cheaper than what it was actually used to be.
Right.
Even many of the pharma companies have brought it to very low levels of price. So most of the people are able to afford it, but we are not able to use it beyond you can say 50 mg twice daily dosing because
Right.
not because of hyperkalemia. Rather, our main constraint is the drop in blood pressure. So I
Okay.
have many patients who have called me that, sir, I'm feeling dizzy and suddenly the BP is less than 80 by 50 in majority of the patients. So I think that in such patients where ARNI is not well tolerated, we have used Vericiguat. And what cardiologists like about Vericiguat is it is actually hemodynamically neutral. So there is
Okay.
no much fall in blood pressure, especially if Vericiguat is initiated at a dose of 2.5. Now it has been shown in various trials that use of four pillars are important. So in case you are not able to use one of the pillars, like if you're not able to use SGLT2 because of the troublesome UTI or any other symptoms, or you are not able to use ARNI because of hyperkalemia or hypotension, I think Vericiguat is a good add-on.
Okay.
Second, once the cost will cut down, very cigarette cost will cut down, it will definitely become the fifth pillar because it is actually acting through a different pathway. And I think that most of the my patients are actually showing a good benefit. So I
Okay.
am personally using Vericiguat to a lot number of patients because truly saying that I use ARNI in my 90% of heart failure patients, especially with reduced ejection fraction, but not that everyone is tolerating it well. So I have
Right.
to stop it in, you can say, some 20-30% of the patients.
I think we got a super added information. So I think that's a bonus for most physicians will be listening to this talk. So something in detail about beyond the pillars that we were going to discuss today. So thank you, Dr. Purneshwar, and thank you, Dr. Banu, for initiating that question. So I think it's very important. So I think now let's move on to the investigation part. So I would like to ask Dr. Pawan that in the endocrine perspective, so what would be a endocrine workflow of management where you would like to start thinking about, or how will you evaluate a patient where you are suspecting heart failure, and what are the symptomatology that you would like to look at and evaluate this patient particularly in future.
So any patient, diabetic patient, we do an annual complication screening with a KFT creatinine and a urine albumin creatinine ratio, serum potassium. And if patient is symptomatic patient, we or patient is obese, we should suspect heart failure in such patients who have breathlessness out of proportion to their comorbidities. Many patients, obese patients, are having breathlessness, walking without any coexisting asthma or CAD, we should suspect heart failure with result if patient saturation and should get an anti-proBNP also. And for glycemic control, we can get an HbA1c and LFT and CBC for annual evaluation.
Yeah, so I think that's an important point that you mentioned over here, that I think any patient with breathlessness that is out of proportion to his underlying state, and as well as somebody with easy fatigability should also probably can be evaluated. That is unexplained fatigue that the patient is experiencing. And some patients do come with a little bit symptoms of probably swelling and anasarca like symptoms, or particularly pedal edema is also an important indicator, and where you would like to evaluate them in a pattern that we see. First we look at the glycemic control, and then we look at the other kidney and heart related parameters. So a question to Dr. Bhanu, I think that's are you able to hear Dr. Bhanu?
Yes, I can.
Yeah, so creatinine is always ordered, but could you just emphasize to our physician friends that why it is important to also get a EGFR, and what's the role of EGFR, and why it's a better modality as compared to just doing a serum creatinine?
Okay. So we have to understand about creatinine a little bit here. That it is a waste product, as we are all aware, but it has to be understood in the context of the muscle mass that your patient has and the GFR equation. So just a quick comment about GFR equations. So there are two major GFR equations that we are using. One is the CKD EPI and the other is MDRT, easily available on internet and mobile apps. If your patient, you're suspecting 60 and above GFR, CKD EPI has a better data which measures the your GFR accurately. If you're expecting a GFR of less than 60, I think an MDRT equation does a better job of measuring the GFR accurately.
Okay.
That's the other aspect. Second is the creatinine. What is happening to most of the guidance that we are getting, especially the physicians, the moment patient gets a little bit of higher creatinine, they tell the patient to stop taking proteins, decrease your protein intake. Before you make that comment, you have to understand what is the, how the intake currently of the patient, your current diet that the patient is taking. And believe me, at least even in my private practice, I easily see protein is not something which Indians are regularly taking. There's vegans are taking hardly any protein, myself being a vegan. And even the non-veg eaters, the so-called non-veg eaters, are taking it once a week. So your normal diet itself is actually only 0.7, 0.8 gram per kg per day. The moment a patient comes with a higher creatinine, you tell them to take, stop your cereals, stop pulses and things like that. Their protein intake goes down to below 0.5 and they become extremely malnourished. Their muscle power goes down. They're unable to do their normal activities of daily living. And that is something to be avoided totally.
Right. Dr. Bhanu, but we will definitely come out these aspects in the lifestyle modification part. But would you like to talk a little bit about EGFR, that is why it is important and how it can probably take you in the right direction?
Rather than EGFR helps you to put the patient into the heat map perspective that we very famous for the albuminuria and the GFR aspect. You put them on the heat map, you clearly tell, are able to see whether it's green and or in the greener side or the red side. It helps us to highlight to the patient that where the disease is progressing and how fast it is one aspect. That is from the prognostic aspect. The other is also we have to understand that GFR is that equation of GFR, that is the heat map basically. Every patient who even have as a normal creatinine of let's say 0.8 becomes at the age of 65, 70, that equation makes you a CKD, which is not the thing.
Right.
So we have to understand that this equation actually and that heat map unnecessarily brings the trauma to the patient that he has become a CKD patient.
Right.
So 1.1, 1.2, 1 sometimes create an unnecessary anxiety in patient's mind, extra referrals to the nephrologist, and lot of drug. At the end of the day, it causes a lot of comorbidities in the patient's mind. So we have to understand this thing. So at the age of above 60, you have to understand that there is a separate equation which helps you to get age-related GFRs.
Right.
So in someone with a GFR of 60 and above, we should not create that fear in their minds that they're a CKD patient. See
Right.
what there's a parenchymal injury there is or not, and then
Right.
whether
I'll continue with the discussion related to EGFR with him later. But I think Dr. Purneshwar, how would you, as a cardiologist, like to investigate a patient with heart failure? Any particular
Okay.
pattern that you would like to see on 2D echo?
So,
Or
see, what we see in our practice is what are the patients who are mismanaged or not diagnosed properly is the heart failure with preserved ejection fraction. So,
right,
those are the patients who are late diagnosed, not initiated on the therapies which are actually required in such patients. So, I think that NT-proBNP is a very useful tool in most of the, you can say, general practitioner's hand or physician's hand, where you can actually use it to understand whether it's you are dealing with a heart failure or not. Second, that you should always get a echo in a good center where they can, if the ejection fraction is preserved, they can tell you about the LV end diastolic pressure or the diastolic dysfunction in such patients, so
right,
that you can easily recognize heart failure with preserved ejection fraction. So that is
right,
one thing. Second, whenever I encounter a patient who is presenting with symptoms suggestive of heart failure, like shortness of breath on exertion or exertional breathlessness, easy fatigability, even some patients with palpitation and pedal edema, we do use first anti-BNP and echo. Second
right,
most important is UACR, urine albumin creatinine ratio, as Dr. Pawan has
right.
already told, because that
Yes,
is a very important prognostic marker for cardiologists also, because
right,
that says that whether how is the risk of progression of the disease going on.
right,
Especially if you're dealing a diabetic patient with heart failure,
right,
UACR becomes the utmost important thing.
right,
And then we do evaluate the other things like presence of anemia, like hemoglobin, calculation of EGFR, any variations on the liver function test, thyroid function test, especially because many of
right,
the patients, especially diabetic with heart failure, have hypothyroidism in association. So these are the basic things, but we do follow up the patients with NT-proBNP because that's a very good marker. It shows whether you are able to decongest the patient or not. I always ask the patient to weigh themselves because weighing is a very good way to understand whether they are accumulating fluid or not.
right.
So those are the things which we do it, and most of the patients do follow up nowadays at least at 2 or 4 weeks interval. So these are the
And
things which we
anything particular, Dr. Purneshwar, would you like to tell about the global strain in echo that we see? Or
So we do
is
use, but I think that it is most of the people don't know how to use it. It is
right,
only at very good centers that we are using global strain and other things. And it is especially useful when we are dealing with heart failure with preserved ejection fraction, where
right,
you have to see the strain index and a patient who have been initiated on some therapy, like you can understand the what we say chemotherapy. So
right,
basically onco drugs. So in
right,
those patients, especially the drugs which can actually decrease your heart function. So
right,
detection of early you can say heart failure. It is very
right,
important to always measure the LV longitudinal and global strain, which
right,
we do in most of the times. And nowadays we are also measuring something called LA strain, which has been
right,
found to be a very useful marker in patients with heart failure with preserved ejection fraction.
right,
But I
right,
think still they are the most underdiagnosed and undertreated patients, heart
right,
failure with preserved ejection fraction. And
right,
definitely it entails a broad spectrum. So those are the patients which will require a close togetherness with a nephrologist as well as the endocrinologist to control their comorbidities as well as the symptoms.
right. So I think that's an important message that all three of you gave over here. While investigating a patient, Dr. Pawan in particular spoke about treating the glycemic counterparts, looking at the HbA1c and also performing an annual checkup that actually entails in doing a retinopathy screen also looking for other complications like neuropathy, and also looking for thyroid dysfunction. An important point that Dr. Bhanu mentioned is we just need not look at just the creatinine, but we need to also look at the EGFR and also adjust it according to age in particular whenever we are taking into consideration. So there are specific formulas that actually give us age-related EGFR. I think Dr. Bhanu, can you elaborate a little bit about it?
Yeah, my connection was lost. So I wanted to make two more points about the GFR aspect. That the creatinine actually gives you a false value in two conditions. One is the our frail patients, where they are in the extremes of muscle mass, where they are CLD patients and chronic heart failure patients who have become cacaxic, and the other is in the pregnancy, where it does not play a great role. So we have to, in the short of these, in these scenarios, cystatin C is coming up as a great marker where you can calculate the GFR through cystatin C. So there are equations with only creatinine, there are equations with cystatin C, and people are saying if you combine creatinine and cystatin C equations together, gives you a very good middle ground where it covers all aspects. So that is one important aspect.
I think that's definitely helpful for our physicians, that also beyond creatinine there is something to look at. And I think urine albumin creatinine ratio still forms the cornerstone or the basic hallmark where we entail about what it entails to both the nephropathy risk as well as the cardiac risk. And as Dr. Puneshwar also highlighted the importance of 2D echo and also the role of NT-proBNP. Unfortunately, it's available, but it's comparatively a costlier investigation. So on case-to-case basis, I think it can be used the right way in diagnosing and especially in differentiating in certain situations. Probably, like if you want to differentiate between respiratory causes and cardiac causes, I think it can be particularly used. And he also spoke about using 2D echo in the right perspective. Some parameters in the 2D echo that need to be looked into, and he also spoke about using the global strain pattern that is particularly useful in patients with heart failure with preserved ejection fraction. Now coming to something about some special scenarios. Before that, I think let's move on to the lifestyle interventions that we need to do. So Dr. Pawan, would you like to highlight on the lifestyle measures that you would like to advise in such a patient in pertainance to both the heart failure as well as the type 2 diabetes?
Very important is, sir, the intake of low salt diet that would entail less than 5 gram per day. And we have to tell that the normal Indian diet is almost double. So the patient has to be made aware that you have to make the food bland and provide only half a teaspoon to be consumed throughout the day. Secondly, protein restriction, as Dr. Banu had already highlighted that it is not of much use in Indian patients. We are naturally protein restricted. There's only supplementation most likely needed. But in patients who are using the non-vegetarian products frequently or using any supplements, they should watch for a excessive dosage of protein. And thirdly, for glycemic control, the usual avoidance of high glycemic foods, added sugars and simple carbohydrates should be done. That is a common point for all patients. And volume restriction for patients with heart failure, less than 1.5 to 2 liters per day, and or ideally replacing the urine volume with the additional 500 ml. That would be.
Would you like to elaborate anything about fiber in particular?
Fiber, sir, in Indian patients, fortunately, is the intake is fairly good enough, but in urban populations, many a time the working patients are not able to procure the fiber. So there are many easy ways to add fiber, like adding salad to the like a bowl of the what AD recommends. 1/4, at least half plate should be vegetables and or some form of salad. And in addition, some market preparations for fibers are also available, which we can add in a powderless and a tasteless type of preparation to the food, or like a liquid solution we can take.
Right.
At least 10 to 20 grams of fiber per day is essential.
Right. So thank you, Dr. Pawan, for those enlightening points. I think I would like to ask Dr. Purneshwar any comment about using fats or your say on what particular fats the patient needs to curtail or whether he needs to use it, especially because we talk a lot about it in perspective to atherosclerosis, but in particular to heart failure, do you think there is still some role or there is no role at all, or what you would like to say?
So basically, these lifestyle like curtailing the cholesterol, you can say what we use the term, right?
Right.
So I think that in terms of heart failure, it is not that much important as compared to actually dealing with atherosclerosis and coronary artery disease, where we
Right.
are actually trying to decrease the LDL cholesterol of the patient and they're trying to decrease the plaque burden in such patients. Otherwise, in particular, only heart failure with a normal coronaries, I will not suggest my patient to have a too much decrease in the cholesterol-rich food.
Right.
Second, in terms of water, what Dr. Pawan was saying, now what I have changed my practice in the recent time is that there was a latest trial which state that patients who are in heart failure, who has known heart failure, but
Right.
not in active heart failure, you can use liberal amount of water. Now,
Right.
many of my patients, when I was using SGLT2 inhibitor together with diuretic and many other drugs, they used to come pretty dehydrated.
Right.
So now that we do encourage the patient to take liberal amount of fluid, right?
Okay.
And especially when we are dealing with a patient with an EGFR of more than 60. So
Right.
in such patients, we are quite liberal. So if the patient is not in active heart failure and is not in a active functional class, that is getting exertion on the minimal, and there is no signs of congestion, I think we allow now the patient to have a liberal amount of fluid, that is 2 to 2.5 liters and more than that.
Okay.
Right. Decreasing salt intake is definitely important. So whatever amount of fluid you are taking, you should decrease your salt intake at any level of heart failure, as well as CKD, as well as it is important in diabetic patients. In terms of oil uses, there are many questions that what oil should be used. Now, recently the European guidelines have published a chart of, you can say, the food items which are good for heart and bad for heart, and they have labeled mustard oil and olive oil as the best oil for the heart, and
Right.
they have added that these ghee or that coconut oil are far worse as compared to olive and mustard oil, right?
Okay.
So but the idea is to decrease the consumption overall, right? Even
Okay.
in heart failure patient, if they develop coronary artery disease in future or they develop blockages, definitely the heart function will deteriorate further. So it is
Absolutely.
important that especially in a diabetic, CKD as well as heart failure patient, it is important to decrease the amount of cholesterol which you are taking. So most
Right.
important is to absolutely stop solid fat, that is
Right.
butter and the other things which we are taking.
You're
And I
talking about
think that
saturated fats. So we'll
yes,
be talking
some
about saturated
most of the
fats. Yeah.
saturated fat, right? And
Absolutely.
then we should try to consume little. So I'm not saying that if your mustard oil is safe, then you should consume as much as you want. So even that oil should be consumed at the lowest possible limit which is required for your general maintenance.
Right. So moderation would be an important key over here. I
Yes.
think again, Dr. Banu, I would like you to elaborate on the liberal intake of water and what is your take on using the right quantities of water, especially in patients with associated CKD and heart failure.
So I absolutely agree with Dr. Pandey the way he has elaborated. There are only few add-on points to address.
Right.
One is to for a normal patient on day-to-day basis,
Right.
they are usually not calculating their water intake. You know how much
Right.
they are taking every day. So one easy measure to see whether they are accumulating water would be to have a habit of checking your weight every day. Keep it just beside your bed and try and do that. We
Right.
in our dialysis patients we do routinely because to measure how much they are accumulating every day.
Right.
We can utilize this strategy in those patients as well who are on the borderline of the moment you
Right.
stop diuretics or they take a little bit of liberal and you see them with fluid overload status and heart failure and so on. So weight charting daily basis can help. If not daily, at least they can do twice a week. Uh, so that they are able to have some gauging about their weight secondary to the water accumulation. The other aspect is about the salt that I would like to highlight. It is so rampant in our society to take the alternative salts that we take on a daily basis. Even the so it's all over the news. The Tata Life thing is going on with the green color packet, with the potassium extra and low sodium salts. It is marketed that way, and almost सेंधा नमक and काला नमक are the normal things that we hear from our patients कि ये लेना चाहिए, हम तो यही ले रहे हैं regular basis पे सालों से, अब क्या दिक्कत है? So we have to understand from the kidney perspective, potassium is a big problem, and all these low sodium salts have potassium extra in it, and on top of that, we are giving drugs like ACRBs to fenrenone. We have to, the moment you put these drugs, you have to put that bit of fear of potassium in their minds. Tell them about the habits that they do, especially the juice intake, the coconut, and fruits which have extra potassium. There's a beautiful list of fruit with potassium, and about these, especially about these salts. There's such a overlooked situation. Most of the kidney nephrologists would end up telling their patients about this, but I think general physicians and other specialties somehow don't pay much attention on this aspect. So I would highlight, ask your patient what kind of salt they take, and then advise accordingly. I think
So
protein
any-
I've
any
covered.
salt- Yes. So I think any salt is still a salt. So that's a key important message that yeah. So any salt is still a salt. So I think our patients, they need to be watchful of the amount of salts that probably they are consuming. So I think these are some important points that you have mentioned about in lifestyle modifications that the patient need to come to. Now let's move on to some special case scenarios where this is the last part of the talk that we have, and where we are going to have a case for each one of you. So first of the cases that is there, I would like to ask to Dr. Pawan. So yeah, so Dr. Pawan, so this is a 70-year-old male with type 2 diabetes. He has a HbA1c of 8.3%. CKD is stage 3B with eGFR of 45, and he has prior admission for heart failure with preserved ejection fraction. He is on metformin, basal insulin, and an ACE inhibitors. So, what would be your plan, or what drugs would you like to initiate in him, and what you would like to stop, and what you would like to add on? You say, Dr. Pawan.
Firstly, I would like to introduce a SGLT2 inhibitor that would help with both the CKD part and the heart failure part. And once the KFT are stabilized and there's no the volume overload is subsided, then I can think of adding the GLP and trying to decrease the insulin dose so that the obesity part is also taken care of. And once both of these the glycemic control is achieved, we can monitor with the urine ACR. If it's still persistent, we can add on frenulone and monitor for potassium if the hyperkalemia is arising. That would be my plan of action.
Okay, so that's an important point, that I think SGLT2 inhibitors and GLP-1 inhibitors, GLP-1 receptor agonists are an important part, and ACE inhibitors, ARBs, whenever necessary as an add-on. And can you elaborate a little bit about till what stage of CKD we can use GLP-1 receptor agonists, and till what stage of CKD we can use SGLT2 inhibitors? Dr. Pawan?
SGLT2 inhibitors have been used till 20 ml per minute, but they can also be continued till dialysis or the transplantation is needed. And for GLP-1 receptors, there is no renal adjustment required as such. They can be continued, but with a watchful observation that many renal CKD patients have gastroparesis and like uremic gastritis. We should be watchful of the GI adverse events which can be pronounced in such renal patients. And
So
malnutrition. That is a important concern with GLP-1. The appetite comes down a lot.
So I think that's an important point that you have mentioned over here. Whenever GLP-1 receptor agonists, they don't need any dose adjustment, especially in relation to patients with chronic kidney disease. SGLT2 inhibitors can be used till a extent, but new add-on is usually avoided when EGFR declines, and they can be continued even if the patient is already on SGLT2 inhibitors, can be continued even till the very end, can easily be continued. So I think, thank you, Dr. Pawan. I would like to move on to a case that is more important from the nephrologist's perspective. So, Dr. Banu, this case is for you. So, this is a 68-year-old woman with type 2 diabetic for 15 years. She again has CKD stage 3 with EGFR of 38. Urine albumin creatinine ratio is 650 milligram per gram. And she has prior history of heart failure with preserved ejection fraction, for which she actually needed an admission. And presently she is on ACE inhibitors, furosemide, insulin, and statin. So she is probably taking just a low dose ACE inhibitor, like say Ramipril about 2.5 mg. So what would be your scenario? How would you like to handle this case, and what are the pharmacological aspects that you would like to treat in this particular case scenario?
So definitely we have to ramp up the Ramipril dose. I believe up to 5 we should go at least. The Ramipril can go up till 5. And like the previous case, definitely an adding up of an SGLT2 inhibitor here would take the proteinuria down to further extent. And but I would like to do this gradually, not on the first visit. So if the patient comes up with 2.5, in the first change that I would like to make it is to take it up to 5 milligram and see how she tolerates from the blood pressure aspect and the potassium aspect. And then add on SGLT2 inhibitor in the next visit to gradually take this up. I've seen in few cases when you try to become a little bit more aggressive and add on everything together, sometimes causes hypotension and non-compliance and loss to follow-ups. So adding gradually by telling them, counseling them about each and every drug, the importance of those drugs, increases the compliance and loss to follow-up issues. So I think that is important. The other is, I think I missed the BMI of this patient. What was the BMI you said?
BMI is 33.
33. Yeah. So there's definitely a good role of diet and exercise there, plus an add-on of a GLP-1. Definitely can be done in this patient to counteract proteinuria, and of course non-steroidal MRAs also play a role. So all the 4 pillars can come in gradually with counseling at each add-on that you do.
Okay. I think that's an important point that you have mentioned here, that I think up titrating the dose of ACE inhibitors or ARBs to the actual tolerable limit, where you have to keep a watch on or monitor potassium and then use it rightly, and then add on a finerenone-like drug is equally important from the nephrological perspective. Coming to the last case that we have, so this is what.
Sorry to interrupt. One important point from practical aspect is you have to counsel your patient, especially when it comes down to the adding of ACE, ARBs and SGLT2 inhibitors. You have to counsel the creatinine that jumps up, and it is and the reversible nature of that jump. Right. I've seen a lot of loss to follow-up, especially with younger, like myself. We have seen a lot of patients. The moment creatinine jumps up, they always end up telling you that this medicine is not suiting us, and so on and so forth. You have to counsel them in that manner that this is an expected rise. It is a reversible nature. That creatinine jump does not denote a parenchymal injury to your kidneys, and I will gradually add up to these further 3-4 drugs over time, so that they are in the right news. Because more in the age of internet and AI, most of our patients end up asking, we have not been given this and we have not been given that. So this is our plan, and this is how I will do in the next 3 months.
Follow-up question that I would like to ask you: what do you think would be a safe limit where you can think that no, it is just because of just a regular increase in creatinine, but definitely the drugs needs to stop at this end, So what would be the amount of, would it be doubling of creatinine, or what would be the value that you would be looking at, or what would be the EGFR decline that would say no, that this drug needs to be stopped probably?
In the last 40, at least almost in the last 48 to 72 hours back, I was counseling up to 30%, especially talking about ACRB, up to
Okay.
30% is expected. But
Right.
I think recently I saw a credible paper which tells us up to 50% you can tolerate the rise, because
Yes.
they are gauging the importance of these drugs in these patients. So
Right.
up to 50% rise can be there, and you have to see. If the rise is more than 50% and between 100%, 50 to 100%,
Okay.
you can temporarily stop the drug or decrease the dose to half and
Right.
look for variables what has caused this. So
Right.
in some patients, let's say if they have a renal artery stenosis, which is not a common thing to have, it's a rare thing
Right.
to
Right.
have, and whether they are too dehydrated or
Right.
some other aspects effect come in. So there's another concept of something called as a sick day phenomena. Then
Right.
if your patients have gone through a sick day time and they continue to take ACRB, you would see a jump in GFR. So you have to tell them the drugs which have to be stopped during the sick day time. So
Right.
these are the two things that we need to highlight.
Right. So I think that's a elaborated discussion that we have had in the nephrologic perspective. Coming to the last case that we have, Dr. Purneshwar, to you. So it's a 72-year-old male with, now the previous cases were heart failure with preserved ejection fraction. In this case, it's a heart failure with reduced ejection fraction. Ejection fraction is 30%. Again, CKD stage 3 with albuminuria of 450 milligram per gram. Recurrent heart failure admissions. He has an NT-proBNP level of 4200 picogram per ml, albumin of 3.4, and potassium of 4.7, and HbA1c of 7.8. So what would be your plan? So he's come to you for first time, and he's probably taken some metformin. Other than that, he's not on any particular drug. So what would
Right,
you
right.
be?
So first, we should understand that when we are dealing a patient of more than 70 years, especially a
Right.
patient with a reduced ejection fraction, the way we are introducing all the four pillars of heart failure at the same time, we should
Right.
not hurry in such patients who are elderly population, right? Because the
Right.
side effects can be pronounced in such patient.
Right.
So what I prefer in such patient is to start with either beta blocker plus ARNI and to add on a SGLT2 and MRA at a later visit. Or many
Okay.
a times I do prefer to give them ARNI plus SGLT2 and I do add on beta, because many a times beta blocker can be a precipitating factor in heart failure.
Right.
And ideally beta blocker should be gradually up titrated, so we don't
Okay.
see patient in terms of creatinine. Microalbuminuria is definitely a issue, and I
Right.
think that I will like to add on drugs which will decrease the proteinuria. So definitely arni tolerated to the best possible numbers, that is at
Okay.
least 50 mg or 100 mg twice a day. First I will
Right.
up titrate that, followed by addition of a MRA. And definitely now Finrenone is not indicated in patients with reduced ejection fraction. This should be understood. So it is still now, even after the Find Hearts HF trial, it is only indicated in patients with preserved ejection fraction or mid-range ejection fraction. So a patient of 30%, we should use the traditional MRAs, that is the eplerenone or the aldactone. Beta blocker, so definitely I will try to add on all the four pillars of the heart failure, because as you have already told that he has worsening heart failure with a repeated hospitalization for heart failure, then in such patient we must give a trial to vericiguat, which has
Okay.
already been discussed. So this drug do play a very important role when we talk about, because there is no hope of actually treatment in such patients if despite all the pillars you are using and dehydrating the patient, they are having recurrent hospitalization for heart failure. So
Right.
after using the beta blocker, arni, mra and sglt2 inhibitor, I would definitely like to add on a vericiguat in such patients.
And a
And
follow-up
whenever
question
we
to
are with
that,
the,
Dr.
yeah.
Yeah, a follow-up question to that. Any particular beta blocker that you would like to prefer?
Sir, we use three only, that is carvedilol, metoprolol, succinate, and the last one is bisoprolol. Nowadays, we are using bisoprolol in higher numbers because of the higher cardio selectivity, or because it is the highest third generation beta blocker with the most selectivity. But we equally use carvedilol and metoprolol to good use. So among the three, we can choose either of any. It's just about the patient preference and the cost, and you can say the physician's choice at some point that you want to use a carvedilol, whether it's a controlled release formulation or a twice daily formulation. But metoprolol, we always use succinate formulations, not the tartrate formulations, because these have been found not to be helpful in patients with heart failure.
I
Third,
think
most
that
important is we should always offer a device to such patients. I think most
yeah,
of us forget, and whenever we talk about a 72-year-old, somewhere I
right,
think most of the people will not offer a device to a ejection fraction of 30%, saying that
right.
no, it's okay, you be on the drugs and be whatever. But most of the death which happens in such patient is a sudden cardiac death because of ventricular tachycardia and ventricular fibrillation. And based on the ECG and echo finding, I'll definitely advise him for either a ICD or a CRTD device.
So I think that's an important insight that all three of you have given. I think because of shortage of time, I think we need to end the discussion here. But I think it was an interesting discussion where probably at the end of the session, all three of us have converged on the same pathways where we are talking about the glycemic management in perspective with RAS blockade, addition of a beta blockade, and also wherever necessary, addition of various ultimate modalities that are available, even advanced drugs like vericiguat, where we can use in our patients with heart failure in diabetes. And I think that's an important session that we had today. And thank you, Dr. Pawan, for joining here. He is an endocrinologist at Meerut. Dr. Purneshwar, who is a cardiologist in Delhi, and Dr. Banu, who again is a nephrologist in Delhi. So thank you, and hope you have a wonderful day ahead. Thank you very much.
Thank
That
you.
was a
Thank you.
thank you very much.